Good afternoon, everyone. My name is Jennifer Phillip, and it's my great pleasure to welcome you here this afternoon to this afternoon's presentation of Perspectives. I'm very proud to be hosting this on behalf of Palliative Nexus. For those who don't know, Palliative Nexus is a research group whose goal is that all people with advanced illness receive high-quality palliative care. It's equitable, timely, and delivered as a standard of care underpinned by high quality evidence. If I could begin today by acknowledging the traditional owners of the land on which we're hosting this event, the Wurundjeri people of the Kulin Nations, and acknowledge their elders past and present. I also wish to acknowledge any Indigenous Australians who may be in the audience today. Perspectives is a broadcast that we conceived last year in lockdown as a way of keeping up to date and keeping and developing professionally and also keeping in touch. And we've been able to really make the most of the opportunity that doing these things online has afforded, and had some terrific speakers over the period of time, and today is no exception. So today is one of our Perspectives on research, where we are able to hear from world leaders and emerging world leaders on latest evidence and their research findings and what they're up to. And today it's my great pleasure to be giving the podium over to some of our emerging stars. We have two presentations today by early career researchers who are future leaders in the field. The format of today will be that we'll have both presentations. I will introduce the first and then after that the second, but we will have all the questions at the end. So I invite you to put any questions along the way in the Q&A function, and also you can do again at the end when we get going with the conversation that will follow. So to begin, our first speaker is Dr. Matt Grant. Matt is a palliative medicine physician, a GP and a researcher. He holds positions as Senior Research Fellow at the University Department of Medicine and a lecturer at Monash University. And he's recently submitted his PhD, congratulations Matt, at Monash Uni, supervised by Paul Komisarov, Luke Dellings and myself. He's currently living in the Netherlands and working at the Julius Centre for Health Sciences and Primary Care, University Medical Centre at Utrecht. And today he's going to be talking about some of the findings from his PhD. So welcome, Matt.
Thank you very much, Jen, and all of the group at Palliative Nexus for your wonderful support throughout my PhD, this wonderful series of lectures, of which I really feel very privileged to be a part of. My name is Matthew Grant. I'm a palliative medicine physician, GP and researcher, and what I'll be presenting today is really a snapshot of my PhD work, really framed as a discussion. It's a discussion about care in hospital systems, how we perceive provisions of care, and the role of non-professionals within these systems. But first, let me tell you about Gwen, who initiated this research. So I met Gwen probably about 5 years ago now, my work in palliative care. And she was a really enthusiastic, bubbly lady who every morning as I walked into the hospital, I would see her chatting to all the smokers, but she didn't smoke. On the wards, it was a similar story. She'd be talking to all the other patients, their family members and staff in the corridors or in their rooms. I was talking to her one day and asked her about this and what it meant to her. She said, those other patients are the most important part of coming into hospital. She told me about her life at home, where she was often too tired or short of breath to leave the house. When family and friends did come to visit, they often were superficial in their conversations, avoiding talk about her cancer and treatment. She said, here I talk to people, and we talk about our cancer, what medications we're on, which chemo we've taken, and the struggles we have. Sometimes it's nice to know that you're not the only one hurting. In the last Perspectives lecture, Bruce Rumbold proposed that the best outcomes in health, in particular palliative care, occur when the formal and informal care systems work together. He pointed out that as a consequence of increasing professionalism seen throughout the 20th century in health has been a significant impediment to this. This is most relevant in the hospital systems, where care is seen as a collection of formal processes, such as taking blood, surgery, chemotherapy, or the formal clinical consultation, performed by healthcare professionals and received by patients. However, outside of this, there are many other processes not controlled or provisioned through formal channels. Discussions between patients during chemotherapy, a chat with a nurse about their children, family members talking with each other in the hospital about their dying parents. These interactions are ubiquitous in the hospital space, yet occur outside of the structure of formal care provision. Bruce Rumbold mentioned what Klaus Dorner referred to as the third social space, where people can move outside of their formal roles, beyond being a doctor or a nurse, and take up other patterns of interaction beyond their normal discourses and connect in other ways. My aim today is also to step outside the formal academic presentation. Instead, I really want to focus on sharing stories of my research, many of which may mirror experiences of your own as health professionals and researchers in palliative care, and share my interpretations in the hope of initiating a discussion. What I hope to achieve is really to prompt recognition of these relationships, these communities, as being part of the fabric of care. I would like to ask you all to think of a time as a clinician or researcher where you may have stepped outside of what you consider your formal role and connected with someone. I'm not talking about overstepping boundaries, but just connecting or shared something with another person, not as a professional, but as a fellow parent, a football fan, a book lover, as a person. I, of course, thought I'd start by sharing my own experience, or one of them. One Saturday morning, I remember doing a ward round at a hospice and briefly meeting a lady who was probably in her 70s and having the most profound conversation about death and the determination of a good life. The conversation lasted all of 5 minutes and naturally came to its end, and I instinctively gave her a hug. I felt incredibly moved by that experience, yet it was complete in its brevity. Had I not diverged from my clinical role, that conversation would never have occurred, nor the hug, nor the meaning it left with me. I cannot presume the significance for this lady, and that meaning may actually be very different from mine. So the aim of this work was to describe these interactions outside the formal clinical consultation in order to understand their content, outcomes, and contribution to care. As the research progressed, it became apparent that these interactions had patterns which were recurring. Thus, the focus of the work shifted to describing interactions as part of larger social processes that represent social systems that have their own norms of behaviour, ways of sharing knowledge, and potential outcome, what we called informal communities. To explore these, we conducted 3 different studies. Firstly, a conceptual study to propose a theoretical model of informal communities, and followed by 2 empirical studies. The first was an ethnographic observational study in which I sat around in cancer treatment settings of the hospital, observing these interactions for 14 months. Secondly, an interview study where I interviewed 31 patients, carers, staff and cancer support group members of their experiences of these interactions. I'd like to share some of these results, really focusing on the stories being told and the vignettes of what I saw in the ethnography. Throughout this research, I witnessed patients, family members and staff conversing and communing. I saw people meeting, talking about the football, and then suddenly sharing intimate details of their illness, treatment, wishes and fears. Some loved the interaction with others, who felt this was a place where they could feel normal with the diagnosis of cancer, yet directed these conversations only towards the superficial, as this really met their needs. I'd just meet people in here, and I'd chat to them. If it just helps to pass the time, it's nice to see them and touch base with them, but that's about it, usually. You might not talk about too much. I could talk to people more as they're going through similar things, but yeah, it's nice to have these people here to have a chat to. Patients and their carers exchanged information about their experiences of treatment, swapped advice about which medications work to get their bowels working, about the best way to get the doctor's attention, or how to plan your own funeral. Yet this information was presented differently to medical information. It came in the language of stories, the knowledge inseparable from the people within them. Yeah, poor bloke, he could hardly walk. He had problems with his legs too because he'd lost so much weight. I thought, yeah, I'd say to him, look, don't go too hard on yourself. Just think to yourself or tell yourself, I'm here, I'm in the best place, and I'm getting the right treatment. People looking after me and just, suck it in, just go with it. I explained my situation to him and he said, oh, sure, you sort of know a little bit about what you're talking about. Staff were often at the centre of these communities. I saw skilled nurses calming first-time patients by talking about the football, finding out important social information through sharing their own stories, and building relationships that were supportive, flexible and nurturing to the needs of the patients and their families. In this one vignette from the ethnography study, the nurses facilitated this man, husband of a patient, to continue in his carer role for his wife in the hospice, as he engaged in care tasks, entered staff areas and performed almost daily handovers to the nurses. Yet they also encouraged him to be a husband, fluidly adapting to his needs. It's mid-morning in the hospice. Mr. Day enters the staff area where the nurses are gathering. They all know him and welcome him in the space. I'm going to go now. She looks quite peaceful. He provides a report on how his wife has been and the care he has provided. His language is very factual, similar to what a nurse would report during a handover. Do you want to give her a kiss? A nurse asks. Oh, it won't be that long, the man says as he walks away. As he walks away, he becomes uncertain and visibly saddened. After some contemplation, he turns around and walks back to the room. His affect changes noticeably, from the purposeful carer to the emotional and frightened partner. A minute later, he leaves the building briskly, a look of discomfort on his face. Outside of the formal consultation, these relationships function towards strengthening relational bonds, and in doing so, reinforcing the impetus to provide care for others, share experiences and personal stories, and access support. Unlike the medical consultation, the knowledge is focused on personal experience, open to all to contribute and to determine their own meanings. This research has important implications regarding the structural provision of healthcare, to recognise that there are other processes that impact and provide care, occurring adjacent to and in the interstices of formal care processes. This has never been more apparent than now, when healthcare is increasingly shifting to digital mediums or interactions masked in protective shields, where individuals may talk but fail to connect. Care is so much more than a clinical consultation, medications, nursing tasks. It is found within and around these processes, where individuals can meaningfully relate, address their own queries and needs, and access care not available through formal structures. So thank you all very much for listening to my presentation. I'd be really interested in any comments or questions you might have. Thank you.
Thank you, Matt. Thank you very much. So we will move straight on to the second presentation, and then we, as said, we will come back to questions and comments from the audience. But our next speaker is Dr. Kathryn Ducharlet. Kathryn is a nephrologist at Eastern Health, and she also works in the renal supportive and palliative care services at St Vincent's Hospital, where she's worked for some years. Prior to studying medicine, and this is the lovely thing, is that you learn things that you didn't know when you are introducing them. So prior to studying medicine, Kathryn completed a commerce science degree with majors in economics and psychology. She's clinical and research interests in understanding the integration of renal care and palliative care in order to improve the experiences for people with advanced kidney disease, and is about to complete a PhD in this area. So as if Kathryn doesn't have enough degrees, she's doing another. So thank you, Kathryn, very much for your presentation this afternoon.
Thank you, Jenny. I'll just share my screen. Okay. Thank you for the opportunity to talk. It's really wonderful to hear Matthew's results and discussion. And today I'll also be reporting some key findings from my PhD, looking at understanding renal clinicians' perspectives of end-of-life care, renal supportive care, and palliative care. So in nephrology, increasingly we're finding it becoming more challenging and complex to look after people with advanced kidney disease. End-stage kidney disease, or ESKD, we call it for short, is commonly surrounding people who are older, and also it is associated with complex and high burden of multiple different symptoms. There's more and more literature growing around the multiple comorbidities often present, issues of frailty and reduced functional status. And all of these factors can increase mortality risk. And in practice, there are increasing issues around care and treatment planning, as healthcare needs are highly complex and often fragmented. And there are complexities surrounding end-of-life decision-making. End-of-life being defined as the final 12 months of life, and therefore decisions around the risk versus benefit of certain treatments such as dialysis compared with conservative management. So in this context, renal supportive care is gaining momentum, and there have been multiple papers discussing what is renal supportive care and how is it defined. And most recently in 2015, this summary of a conference talked about renal supportive care very broadly, helping patients with advanced kidney disease to improve physical and psychological well-being. And that's specifically looking and focusing on symptom management and quality of life, and education and support in decision-making, and aligning treatment plans with patient goals, and improving coordination of care across medical and social services, and in particular, caregivers and loved ones. However, in Victoria, and also more broadly in Australia and New Zealand, it's unknown what the current experiences of renal supportive care are, and what are the benefits and risks associated with renal supportive care. And despite growing literature in talking about the benefits of renal supportive care, it's unclear why it hasn't become a routine part of nephrology care in Victoria and Australia. Therefore, my research really very broadly looked to understand and explore renal clinicians' attitudes, experiences of palliative care, renal supportive care, and end-of-life care. And this is broadly the PhD study design that I followed. After the literature review, I undertook a large qualitative study investigating renal supportive care, end-of-life care, and palliative care views from many 54 renal clinicians across Victoria. And that's really where I'm going to focus my attention today in terms of the findings. And after this qualitative study, I then went on to do an online survey looking to see if these results from the qualitative study were representative more broadly across Australia and New Zealand. And that's recently been published in Nephrology this year. And then the third phase was bringing together an advisory group, really to integrate all of this data together to then enable recommendations to improve renal supportive care across Victoria. So today I'm going to focus on the qualitative findings that have come from that second phase of the study design. And there were 54 renal clinicians that participated across 5 different healthcare services. 2 were in regional centres and 3 in metropolitan areas in Victoria. And these are the overview of the key results from the qualitative study. Really very strongly across all the focus groups and all the data and all the analysis that we undertook. Really, there was a very common theme around difficulties, challenges, and sometimes feeling compromised when recalling end-of-life care experiences, and aspirations to try and improve those difficult experiences for future patients. And this was consistent across doctors and nurses in all of the renal centres that participated. And I'll go through some of the key results from these 3 chapters subsequently. So firstly, there was very clearly, consistently across all of the healthcare providers, a common theme around uncertainty and difficulty around end-of-life care. And part of that was underpinned by the healthcare structures supporting renal clinicians in this role. And specifically that was around uncertainty of outcomes, not knowing exactly how to predict end-of-life care for patients. And also when patients were deteriorating slowly or gradually over time, how to best detect and respond to these clinical deterioration. And given this variation and uncertainty of healthcare systems, there was significant differences describing renal supportive care, the definitions, the clinical scope. Some nephrologists described providing renal supportive care for all renal patients as part of their daily routine, focusing on symptoms and quality of life. And then other doctors and nurses saying, look, we don't do any renal supportive care, that doesn't exist. And there was a huge variation in between these 2 views. And there was also limited integration with palliative care earlier. So in the final phases of life, for example, when a patient was deteriorating and dialysis was withdrawn and a patient was imminently dying, it was very clear and very comfortable to refer to palliative care at that point. However, there was uncertainty about, well, maybe we should refer earlier, but I'm not sure. There was uncertainty around when and how to do that, how to initiate the conversations around dialysis, palliative care. And there was also variable support for renal clinicians with end-of-life care in terms of education, communication skills, and also opportunities to debrief when there were really difficult experiences. And this quote here describes a nephrologist's experience when thinking about patients who are on dialysis long-term and are slowly deteriorating from often other comorbidities that are progressive over time as patients get older, and how at the moment we're not really putting a lot of things in place, preparing for patients for what is inevitable. And the second main theme that really shone in all of the results that were found in the qualitative study was around difficult experiences of end-of-life care, highly challenging and at times distressing for renal doctors and nurses. And there seemed to be 2 main features associated with the most difficult end-of-life experiences for renal doctors and nurses. And firstly, it was around barriers in decision making before the final phase of life. As I mentioned earlier, there was recognition that patients were deteriorating and they could be dying, though unclear markers or triggers to initiate conversations or changes in management plans. And this was underpinned by these three sub-themes that you can see. Firstly, mismatched expectations and engagement. And this was pertaining to renal doctors, nurses, patients and family members having different expectations of what treatments like dialysis could provide. Even in critically unwell patients in intensive care, patients would describe thinking that dialysis was going to improve the situation, and dialysis nurses feeling like this patient's going to die soon and I'm feeling quite distressed that we're continuing dialysis. And also differences in engagement, as in doctors and nurses were keen to engage in conversations about end-of-life care, though when they tried, patients often didn't want to for different reasons, many variable reasons. There were also competing wishes, and this was described as patients wanting to continue dialysis, even though it was becoming increasingly risky and more difficult to provide dialysis as a patient was dying. And other differences in terms of quality of life. So, for example, a young patient with perceived terrible quality of life and wanting to talk about stopping dialysis, and nurses and doctors finding that very uncomfortable when they viewed the patient's quality of life as reasonable and not really understanding where these requests were coming from. There was also highly complex and medical issues associated with difficult end-of-life care experiences when there were multiple specialty teams involved, for example, renal and neurology, respiratory, cardiology, all involved, all trying to help improve the situation for a patient that was critically unwell, and how to balance all of the different input from the different specialties to come up with a cohesive plan. The second main theme was around rushed or late decision-making when withdrawing life-sustaining treatments like dialysis. And renal doctors and nurses talked about feeling patients had limited preparation in terms of preparing for end of life and dying and planning for that. There's also uncertainty of outcomes and transition points in terms of when to start talking about dying or stopping dialysis, and not knowing when the right time was, because often patients would become unwell, be admitted to hospital, improve a little, go home, and then come back in unwell. And often, the illness trajectories were not clear cut and not easy to foresee. And then also there was a consistent message around continuing dialysis. So if there wasn't a plan in place or a decision made around stopping dialysis, well then the systems would continue and dialysis would be continued to be provided, even as it became more difficult or risky to provide dialysis as a patient was becoming more unstable. And this quote that you can see in the bottom of the slide here tries to sum up some of the difficulties and experiences that renal doctors and nurses described around end-of-life provision. And this nurse described a man who'd been on dialysis for a really long time, for 14 years, and she could see it was inevitable that he was heading down a trajectory and he was dying. However, he still had life goals that he wanted to participate in. And she says, I don't even know if he made the decision to stop himself in the end because he was so delirious, he had an ischemic leg. It was an awful way to go. And there were a lot of experiences like this where patients were deteriorating. However, attempts to engage in conversations about planning, were very hard to progress for many different reasons. And then there would be an acute event or a sudden decline that would precipitate an admission and withdrawal of dialysis. And there were also really positive experiences of end-of-life care too. It wasn't all difficult, it wasn't all challenging. There were also some really wonderful and rewarding experiences as well. And this really pertains to the core values that renal clinicians described as important when considering their experiences of end-of-life care. And these three core values were around the commitment to continue to care for renal leadership, and that was highly valued as important, guiding care and helping lead discussions around decision making. And patient choice was really fundamental, and a lot of activities and behaviours were centred around helping enable patients to make choices that are best for them. And what we found was the highly distressing experiences that some renal doctors and nurses described occurred when one or more of these values were viewed to be compromised. If they were unable to commit to looking after patients and they were taken away, or not being able to continue looking after those patients, or if they viewed that leadership wasn't there in terms of decision making, or they felt that the patient's choice had been obscured or influenced by other external factors, then they describe these very difficult and distressing end-of-life experiences. And this is one example that was described by a nephrologist that you can see in the quote here. And in terms of the positive experiences of end-of-life care, these values were still shone through. And if all three of these values were maintained and honoured, then there were really positive experiences described. And the nurses talked about this ongoing commitment and the opportunity to be involved and help facilitate good end-of-life care that was really centred around patient choice and their wishes, which is described here in this quote. And so some of the key findings that I'd like to highlight now is really that what we found was dying can be really difficult from renal clinicians' experiences. And it seems to be that historically and currently, systems, training and resources are focused largely on renal replacement therapies. A lot of attention, a lot of clinical time, a lot of resources are really focused on planning and preparing and performing dialysis and transplantation for patients with end-stage kidney disease. And there are opportunities to also consider patients that are managed conservatively, and also how we stop dialysis. If we've spent so much time and energy focused on providing dialysis, we also need to spend time and energy thinking about how we facilitate and support patients when they stop dialysis. And there are multiple barriers and difficulties evident and experienced by renal clinicians. And this can result in conversations about dying being avoided or happening very late, which then perpetuates the difficulties in helping support patients with good end-of-life care. And this quote here describes that experience of really very much being educated, socialised around the importance of providing renal replacement therapies, and therefore the difficulty that some renal clinicians describe and feeling confronted when you start talking about taking these things away that are so important and that we've spent so much time providing. And it's a big part of care that renal doctors and nurses provide for renal patients. And there are so many ways forward from this research in terms of thinking about the key messages from what I have discussed so far today. It's very much around the patient's choice, their control, and really helping facilitate them planning much earlier than when they're critically unwell and it becomes really difficult to ensure that patient choice is at the forefront of end-of-life care. And also very much the coordination and collaboration within and across services. I haven't emphasised this today in the results that I've described, but what did come about was the importance of the collaboration between renal and palliative care, and also the collaborations between hospital and community-based services. And if we're able to improve this, then that provides a more seamless experience from the patient's perspectives. So in conclusion, end-of-life care is really critical and an important part of renal care, and professional values inform and influence experiences of end-of-life care for renal clinicians. And we need innovative and collaborative system-wide approaches to develop more routine discussions and end-of-life decision-making as part of renal care earlier than the final phase of life. And potentially there's a role for renal supportive care to help earlier development of palliative care and integration of palliative care in nephrology, and that it could include education and support for renal clinicians. And I just thought I'd spend a moment reflecting on the journey of the PhD that's coming to a close soon. And it's been really wonderful to be both a clinician and a researcher and working and researching in a similar space. And I feel like that's helped develop both areas. And also having the viewpoints of palliative care and nephrology has been really interesting along the way. And it's been wonderful to have the time and opportunity to think deeply about what we do as renal clinicians, why we do it, and what's so important in our professional roles. And I think that's quite unique in this research and hasn't really been published before. And so I'm excited to share that with you today. And I also am very thankful for the partnerships that have developed and encouragement along the way. And I'd just like to acknowledge my supervisors, Jenny, Phillip and Hilton Gock, and the team at St Vincent's in terms of nephrology and palliative care, and the funding from the University of Melbourne and Safer Care Victoria. Thanks.
Thank you, Kathryn. Thank you very much, and thank you both for splendid talks this afternoon. We have a bit of time for some questions from the audience, and I might, there's been a little bit of chat going on as you've been talking, so I might just perhaps start off with a couple of comments that were made, maybe first to you, Matt, congratulating you on your research from Nora Rafari, and saying it's great to be able to connect with patients in a non-clinical context. Similarly, Jackie Jung saying this is a very valuable aspect of care that sort of is organically provided, which is a nice word. And Jackie makes the comment that she sees it in some settings of care, and perhaps also in her comment, maybe not in all. And I'm just wondering, Matt, if I could take that to the next step and ask you, what do you think might be important for an atmosphere in order to be able to be conducive for that sort of care?
Yeah, look, I think I'd certainly agree with your comment, Jacqueline. I saw some spaces where it was really, that was part of these normal care processes, and others where people really stuck within those more formalised roles. I think number one, it comes from the staff, and also an understanding that there are these things that we do that do contribute to care significantly. And I don't think this is, quite one of the challenges we were trying to really address with this research is actually to formalise, to understand what actually is happening within this, to map this kind of this realm of informal care that is processed, so that especially, those, you have the more experienced staff that may do those things quite organically, but those new staff that come to there, how do they understand the importance of having that chat about, growing up in Tasmania or following a football team, and how that really contributes. So I think it's staff understand. The other thing is, of course, environment as well, that many, especially acute hospital spaces, are really, there's rooms, there's corridors, there's patient spaces, there's staff spaces. And there's very limited amount of spaces which allow people to coalesce, apart from kind of the shared patient rooms, and really no space for visitors as well. So having those spaces where people I think it's especially important that people can choose to go to those spaces where, if they were wanting to interact with other people, such as the kitchen in the hospice, or the lounge area in the palliative care unit. Really important, especially it gives them that control over the interactions. And also shared spaces as well, where staff meet patients and family members. That isn't a hugely busy corridor where you're kind of jammed in between a chair and a blood pressure machine. Somewhere where they can just go and have a normal chat that may not follow those very clinical trajectory of discussion, which may be about something totally different, where people can just connect on another level.
Thanks, Matt. I might segue, because there's been a comment. One of those spaces could be in the dialysis unit, Kathryn, and Adam Steinberg's asking you to reflect on perhaps some of Matt's work in the context of kidney disease. And it strikes me that having dialysis, there's a lot of potential community and same day, same time next week type thing.
Yeah, absolutely. I think the dialysis social network is a big component of care experiences of dialysis patients. It's very important for those patients, and it's built up over often years and years of doing dialysis at the same time with the same group. And I think it would be fascinating to do more of the work that you've done in that space, because it's so critically important from the patient's perspectives. And I think it would be, fascinating. And I do recall, some of this has been acknowledged in different ways internationally. And I do remember the World Congress that was in Melbourne in 2019, and they had a series of short videos where they had, different music and art and dances and all these different experiences in dialysis units, to kind of, I guess, build on the fact that it's a shared space, and it could also be very much an enjoyable space. It doesn't have to be just about the treatment. Does that make sense? And it's fascinating to think about that more. And I think there's a lot, we could do thinking about that in terms of patients' perspectives and improving that, and also just understanding it first to see how it could be improved or understood from our perspectives.
It's sort of remarkable that we're so late to think about it, isn't it, really? I mean, in the same with aged care sort of settings, it's remarkable that we haven't made them. It's a really great place to be if you needed to be somewhere. Nora has asked a question, Kathryn. Made a comment about in some cases patients' families are really determined to do everything and pull out all stops regardless of how it's sort of going. And I wonder how that sort of fits in with your notion of patient control and choice, and how you'd sort of navigate those tensions.
Yes, yeah, absolutely. That did come across and was part of that discussion around competing wishes, as in sometimes there were situations where there were family members wanting one thing for their loved one. Patients may or may not have the capacity to elicit their own wishes, and then care teams and their wishes, and sometimes there was conflict and difficulty. And renal nephrologists talked about trying to navigate as best they could in very difficult circumstances, and often using family meetings and sequential family meetings to try and find common ground, and therefore together make a plan forward. Though it would come to a point where if they couldn't find common ground, well then if it became impossible to do the dialysis, then it was kind of like a critical moment. And then often at that point, family members would realise, okay, my loved one could be dying, even though we're, you know, giving every possible treatment available. It's, you know, still not working. And so trying to gradually find that acceptance is very hard and highly emotional, and often in a situation where you don't want the person to die. They're your patient for many years. You want to continue looking after them, but you know, unfortunately, patients do die, and it's about trying to find the best, most comfortable way for them to have that experience.
Maybe a nice segue. Kayleen has put a comment in the Q&A that we put a lot of importance in holding space for silence and being comfortable sitting with silence so that patients have got time to process what's going on. And I guess in a way that's a sort of a bringing together some of both of your work, normalising the environments to sort of enabling things to happen and unfold. I just wanted to finish off by asking the last sort of question of Matt, if that's all right. Many of us wouldn't have done ethnography as a research method. Can you give us a few, maybe 3 big pointers that you found interesting about doing ethnography? Or 2 if you can't think of 3.
Yeah. Look, my initial reaction is it's bloody tough. As a clinician, being kind of asked to then sit in a clinical space and not do nothing, but sit and observe and not be a clinician. I think, you know, what are my learnings from it? I think it has a huge amount to add to our understandings of clinical care, that we can actually see the processes that are going on in clinical care, reflect on them, improve it, that we're not only just looking at the outcomes of those clinical process, but what actually occurs, what is every component of these processes. And we'll probably find that a lot of those processes, the important bits, are the things we don't think about, such as, you know, the chat about football that's happening while someone's taking blood and things like that, that really goes a long way to making that person feel comfortable and actually having a good experience of it. I'm trying to keep this short. The other experience, yeah, it's just difficult. It's a very valuable and rewarding research method, but I think having people around you with experiences, you know, of it is, you know, it's something not to be taken on lightly, would be my other comment. So I'll leave it there. Thank you.
So if we're wanting to do the study, we'll all come knocking on your door. Thank you.
Yeah.
So I might bring today's session to an end, and it's been a terrific opportunity to peek into your work, and thank you very much for sharing it with us, and we look forward to your continuing emerging stars shining as brightly as I have today. So thank you very much. I wanted to also thank the team behind here today. So that's Stacey Panozzo and Tanya Fraser. Thanks for making today happen and for doing all the organising and the running around, and also holding all our anxieties when the internet doesn't work very well. So thank you both. Thank you to you, the audience, for coming along. It's always good to meet up every few months on a Wednesday afternoon and have these sessions, and I'm really enjoying them and getting to hear lots of great things and enjoying the questions. So thank you very much for being part of the event today. I just wanted to showcase that on the 4th of August, we have Dr. Lucy Selman, who's the Senior Research Fellow, the School of Population Health Sciences at the University of Bristol. And Lucy is a terrific social sciences researcher, been involved in palliative care research for quite some time. And more recently, she's the co-principal investigator on a national study of bereavement during COVID-19 in the UK. So I hope that you'll be able to join us then. And thank you everyone once again, and have a great evening. Thank you.